All right, you ready? Hey, welcome everybody. Welcome to ADR Support Group. I have a surgeon here, Dr. Simon Harris, out of Canada, that we wanted to introduce everybody to. And I think everybody's going to find this favorable in Canada because you've been limited on your options, and I think you have a great option from what I've understand. But Dr. Harris, can you tell us a little bit about yourself?
Thank you, Jamie, for the introduction. So I'm an orthopedic spine surgeon. I did my medical school in the University of Cambridge in England, and then I did my orthopedic surgery training at the University of Toronto in Canada. I followed that up with the fellowship at the Toronto Western Hospital for a year, then transitioned into practice in Scarborough, which is the east end of Toronto, where I practiced for about 9 years. And then recently, the end of last year, I moved my practice over to the west end of Toronto at the Mississauga Hospital to our large regional spine program there. If we're going to talk about disc replacement today, which is obviously the main focus, and particularly how it sort of relates to Canadian patients, my experience in disc arthroplasty has really been over that sort of 8 to 10 years in my practice. It was interesting because it's not something that we trained in. It was not something we were taught, but when I went into practice, there was a senior surgeon who was retiring, had a vast experience of lumbar disc replacements and some experience in cervical disc replacements. And so it was really through him, Jamie, that I learned to learn the indications for the surgery, learn the process, and built that experience.
You know, that's a fantastic resume for sure, especially for, like I said, what we're kind of looking for. So how long have you been doing artificial disc replacement? 8, 9 years?
Yeah, it's about 8, 9 years. I'd say the last 4 or 5 years, excluding a little dip during COVID, has been my highest volume years. In particular, cervical disc replacement has been my main focus. So went away for from the lumbar disc replacement work probably about 6 or 7 years ago. But the cervical disc replacement is a big part of my practice.
So you're not doing lumbar artificial disc replacement?
Not typically anymore, no.
Okay. And then with the cervical, what devices are you using typically?
Yeah, so when I started, I was using the ProDisc, the ProDisc C. Went through the different stages, the original ProDisc, the Vivo, and I think the most recent one. And then in 2018, I transitioned to the Mobi C, which was originally a product from France, from LDR, which was purchased by Zimmer Biomet and now owned by ZimVie.
So you're using primarily the Mobi C.
Yeah.
So why did you, if you don't mind me asking, why did you switch from the ProDisc C to the Mobi C? What was the thinking behind that, or the rationale?
So initially, one of the main things that made me switch to the Mobi C was the lack of, or the absence of the keels. And the keel cut part of the ProDisc made the process a little bit more challenging in terms of getting the implant exactly into the right position. That was one of the things that drove it. And also, the other main leading point with the Mobi C is, by its name, has a mobile core. So the central plastic component, the polyethylene component of the disc, is sort of semi-constrained. So it allows for some movement, some settling. And that's important because everybody's spine is different and everyone's anatomy is different and everyone's degenerative process is different. And so often that freedom of motion that you get with a Mobi C allows for sort of the centralizing and into its normal center of rotation, whereas the ProDisc, if you get in there perfectly, it's good. If it's off a little bit, then it can often lead to a bit of clinking, clunking, particularly in multi-level disc replacement. So that's why, for that experience, I went to the Mobi C.
And then what is your range on your construct? You know, are you doing hybrids in the cervical? Are you doing strictly disc? How many levels, etc.?
Yeah, so I primarily try to stick to just isolated disc replacements. The hybrid discussion is a really interesting piece. And I've done a few cases in a hybrid situation, but the purpose of the disc arthroplasty is to maintain motions and prevent adjacent segment wear on the other levels. So by the time someone's already had, say, a 2-level fusion, by doing the disc replacement on the level above, you wonder how much real advantage you're giving to that patient. Whereas I like to try and stick to isolated disc arthroplasty. And typically, 1 or 2 levels. I've done a 3 level. Beyond that, the rates of dysphagia, injury to the recurrent laryngeal nerve, and some of the technical complications of the operation does go up when you get to 3 or 4 levels. So typically, 1 and 2 levels is the go-to for most patients.
And then when you're looking at a patient's images, what are your contraindications for not doing the surgery for a patient? That way they're like, okay, I'd like to see this guy, but I have this. Maybe I'm excluded or not, right?
Gotcha. So when I started practice, you're really kind of looking for that zebra initially. You're looking for the sort of that perfect patient who has the nice soft disc herniation that you're not it's going to be a straightforward operation, and you're going to get that implant in the right position, and everything's going to work out very well. And as you kind of build your skills and confidence, you get to expand your indications a bit. There are certain things that are complete contraindications, obviously tumor infection, rheumatoid arthritis, or the presence of any significant neck instability. One thing that I was initially concerned in the first few years of doing these implants were patients where the disc was really collapsed down, where it was almost kind of pseudo-fused. And the concern being, can you adequately restore the motion in those patients? And I found, as I kind of, worked out techniques to get a better release, to restore that height, actually found that wasn't a huge contraindication if they were really collapsed down. I wasn't always looking for that soft disc. And so building that sort of experience into more advanced degenerative changes, that was a key thing. So that sort of leads on to this idea of, if the patient already has some kyphosis, if the neck is starting to bend forwards a bit, you kind of have to have a bit of an understanding of how much of that is coming from the disc versus how much of that is static and won't be corrected. Because you don't want to put in a disc replacement with somebody who's fixed in kyphosis. It's not going to benefit. So you have to be able to restore that lordosis. And so I think a lot of that comes with experience as you realize how much you can recreate the height anteriorly to correct that kyphosis into a more normal lordotic position. And so that's become less of a contraindication. It's certainly something that I look at and I pay attention to, and I have to question, can I restore this person's normal alignment? But overall, it's not a major contraindication for the procedure like initially it was thought to be.
Fantastic. I totally agree with you. Moving forward, that sounds like a lot of, possibilities for some patients out there in Canada. I think that's basically what we're trying to do in a nutshell, is to kind of find some more resources for Canadian patients, and it's kind of been limited to a point. There's not a lot of people doing it. We hope, in the future it will, and hopefully with the more expanding devices we have out there. Like I told you, we talked about a viscoelastic disc and some of these other ones. It'll make the contraindications even a little bit more acceptable going down the road. What would you like to see in the future with spine care?
I think when it comes to Canadian patients, a big thing is going to be access to care and bringing the disc replacement more forward. So having more centers that do it, maybe a few centers of excellence where there's someone overseeing the quality of the implantation to make sure that we're doing a good job. Spreading the word that it is available out there, it is a great operation, and that it is available for you. One big change that's actually happened in Ontario last year is that a lot of the research has been done on disc arthroplasty, and I worked with one of our oversight groups called Health Quality Ontario, which provides information to the Ministry of Health on what procedures should be funded by the government. And previously, anterior cervical discectomies and fusions, ACFs, were funded additional specific funding to the hospital, and that encouraged the hospitals to provide the infrastructure, the resources, and the volumes of patients, because that would improve their income. But disc arthroplasty wasn't. And so disc arthroplasty was seen as a cost burden to the hospital because the initial upfront cost was higher for the implant for a disc replacement versus a fusion. And the hospitals weren't recouping that money from the government. Now that has changed since last year, where following the publication of the research from Health Quality Ontario, that the hospitals are now funded in the same way as a ACDF. So There's been a lot of interest from the other Ontario hospitals in training. So I'm working with ZimV on some consulting, some cadaver labs, and sort of spreading that word, having meetings, having on hand experience. Surgeons coming to the OR to see how I do the procedure, to allow us to kind of spread that word and get it out there for anyone who is who's this surgery is an option for them.
And then, most in the US with cervical, we've kind of moved to outpatient. Is yours outpatient or inpatient?
So predominantly outpatients. One of the biggest concerns with doing anterior cervical surgery, whether it's a fusion or a disc replacement, would be the potential for airway concerns after the surgery. So either bleeding or that can cause swelling and obstruct the airway. So typically they've been done as a inpatient procedure. What I found worked very well was I send the patients home with usually a drain in to collect any blood. And then they come back to the clinic the next day. Usually the drain is empty. There's no problems. You take the drain out, check the wound, and that's also an opportunity to ask any sort of follow-up questions that the patient may have. And so I've predominantly been moving to an outpatient procedure for these operations.
That's a great response. And then how do patients find you, right? They're like, hey, I really like what Dr. Harris is saying. Which is the best protocol method for to get in contact, get images to you, and so forth to move forward? Obviously, most of the patients, hopefully in the group, understand that conservative treatment is the best. First start with the PT and try to find as many different outlets before you go to surgery. But like I said, what hospital do you work at? Tell us how we can reach out to you.
Absolutely. So I work at the Mississauga Hospital, which is part of Trillium Health Partners in the West End of Toronto. And the best way to get a referral is through the family doctor. So in Ontario, the family doctor can fax me a referral and give you the number. It's 416-431-6910. And the family doctor can send in the referral, and I will triage the referral, and you'll be seen accordingly, and all organized through my secretary. The family doctor should send in a report of the MRI images so that can be reviewed. Typically, the patients that are a good surgical candidate are patients that have arm symptoms. So either that's what we call radiculopathy, so a pinched nerve giving pain or weakness into the arms, or if they have symptoms from compression of the spinal cord, which is called myelopathy, where it usually affects both hands, numbness, weakness, clumsiness, and sometimes some difficulty with balance and with walking. And so those are the patients that typically are candidates for this procedure, rather than isolated neck pain is often tricky because there's so many things that can contribute to neck pain, whether it's muscular, whether it's from the facet joints, whether it's from other levels. And so isolated neck pain typically isn't an indication for surgery, in particular disc replacement, but it's those patients that have those arm symptoms. That's what we can reliably improve with surgical intervention.
When it comes to imaging, what should all the patients have? What are you looking for as far as like that way when they come to you, like, okay, I've got everything in order for that way you can make the best, question towards them, whether or not they're a patient or whatnot. So what are you looking for before they get to you?
The main thing is definitely an MRI scan within 6 months, ideally, of the time for referral. Just a standard imaging, what we call sagittal and axial T2 imaging, which is just a standard cervical spine MRI scan. It doesn't need to be with contrast or anything like that. Additional imaging at that point is rarely needed. Sometimes I need an X-ray if I'm concerned about the alignment when the patient's upright, or to better assess the arthritis in the facet joints, which sometimes can be a bit of a contraindication to a disc replacement. But those things can be organized on the day. Very rarely we do other things like a CT scan. In some patients where they have some compression from the disc side, rather than being a soft compression from a disc, it can actually sort of be more of a bony bar or disease called ossification of the posterior longitudinal ligament, or OPLL, and that can be a contraindication to a disc replacement. But again, it's very rare, so I don't want patients to worry about that. That'd be something that on the day I would assess and say, okay, we probably need this and this, but primarily just a simple MRI of the cervical spine will be enough.
This has been fantastic. I've really enjoyed my time with you. I think we did exactly what I said we should do in the beginning. We got to the point, we got all the questions answered. And I think any patient that watches this video will definitely be able to complete their assessment and figure out what they want to do in Canada. So I really appreciate you taking the time today and getting away from your practice. We're kind of here in the mid-afternoon, and thank you very much for your time. And I know all the patients are going to be very excited to watch this.
Thank you, Jamie. It was a great opportunity, and look forward to helping whoever we can up here in Canada.